Nice to be here. Thanks for making me come.
Always. So Zeke is the Diane S. Levy and Robert M. Levy University Professor at University of Pennsylvania, Professor of Healthcare Management, Vice Provost for Global Initiatives, and Chair of the Department of Medical Ethics and Health Policy. A lot of titles, Zeke. So we're going to discuss two viewpoints, but principally focusing on Zeke's viewpoint that he wrote with Govind Persad, entitled The Ethics of COVID-19 Immunity-Based Licenses, Immunity Passports, which has been in the news more and more just the last few days, and we'll return to that. But Zeke, before we start, you write on ethics, you write on health policy, you write in other areas, pretty prominent in the media recently. Could you just tell people a little bit about your training background? I don't think we've ever discussed that in our various podcasts.
Well, I did medical school, and after 3 years of medical school, I took off and I went and did a degree in political science at Harvard, focusing on political theory, but I had training in other areas of political science, including international relations and American politics and constitutional law. And then I did my internship, year of residency and fellowship, and then I began writing a lot in the bioethics world, where my dissertation was. And about, 20 years into being a bioethicist, I decided that I wanted to get more involved in health policy, because a lot of the questions I was most interested in were butting up against universal healthcare coverage, allocation of resources, and things like that. And so I began writing a lot more, studying and writing a lot more in health policy. And then because I fortunate enough to get a job in the White House during the Affordable Care Act, got a firsthand look at both policy making and trying to put ideas into action. But I would, if you're curious and you can read the literature, I think, it's possible to come up with some ways of contributing.
Well, you've been invaluable, and I think I've mentioned to people before, you're a member of our editorial board, and you're just a fabulous contributor to JAMA and the JAMA family. So
thank you.
So the ethics of COVID-19 immunity-based licenses, could you say a little bit about your co-author? I always make sure they get credit.
Yeah. So Govind is a former student of mine or fellow of mine. He worked with me at the NIH when I was head of the department. One of the most brilliant people I have trained, for sure. He's a law professor now at Denver University. He's done a lot of bioethics. He's also uniquely trained he has a JD as well as a PhD in philosophy. And we have collaborated a lot on the work related to allocating scarce medical resources. And we've been working on the whole issue related to COVID. We've actually just launched a big project trying to think through how you would distribute a vaccine among countries, not just within a country.
So over the weekend, the United Kingdom announced that if you want to come and visit, you get quarantined for 2 weeks. One of the CEOs of one of the airlines said, well, one of the things that may help airline travel is this so-called, COVID passport, this notion of an immunity passport. What's the science behind an immunity passport?
Well, at the moment, there's no good science, but I think that the presumption is the following, that someone who gets infected with COVID-19 will have an immune response, raise antibodies and other immune cells that can fight COVID-19, and that they will be immune from a reinfection, and they won't also be shedding virus particles themselves, and that this will last for a period of time, years, hopefully, and that would allow us to say they can't be infected by COVID-19, and most importantly, they can't shed it and get other people infected by COVID-19. And I think that would, make them able to do things that other people might not. They might be people who, they can come into the country because they're not going to be carrying COVID, for example, into Britain or New Zealand or other places that, may become COVID-free. Second, you might actually want them for doing certain jobs where the risk of infection could have very devastating consequences, like working in nursing homes or working in the supply chain of food production. So I think these immunity passports, if we can guarantee the science that, yes, in fact, these antibodies are neutralizing, they last for a period of time, a long time, offers, you have to have that science for the advantages, but a lot of people think that science is likely, but we need to confirm it. I mean, we just shouldn't say, well, it's likely people have antibodies. We need to show that that's true.
Right. So for the purposes of this discussion, let's make the assumption that over the next 3, 4, 5 months, we will know if you could test someone, if you know they've developed IgG and neutralizing antibodies, and then over the subsequent 6 months or a year, we will know how long it lasts. Because without the science, this is a non-discussion. So let's assume that the science. So let's start with something you and I already exchanged emails about. Germany in World War II decided to put Jewish stars on the coats of Jewish people. And it led to profound consequences. So stigma, and we're going to go through the different elements of the viewpoint. But can you talk about stigma?
Yeah, so I think we have to recognize what the difference is between having a star because you're Jewish or your religion or, one grandparent was Jewish, and having an immunity passport because you've recovered from COVID-19 infection. So the first is what the lawyers call an invidious category and invidious discrimination. It's taking a totally irrelevant factor, your religion or your grandparents' religion, and excluding you from all sorts of benefits and rights in society. You can't be a member of a certain group. You have to wear this star. You're excluded from certain jobs, and eventually you're put on trains to concentration camps. That is very different than an immunity passport that is based upon not an invidious category like race, religion, or gender, but is based upon your recovering from an infection and being immune so you can't pass it on. Let us remember, we are already penalizing all sorts of people. Everyone in society in some ways has to physically distance because of the threat of being a potential carrier of COVID-19 infection. So I think they're very different kinds of categories. Would we stigmatize people who don't have an immunity passport? I don't think it's a matter of stigmatization. We would simply recognize that they're vulnerable to infection and that they might have an infection being asymptomatic unless we test them. So I think these are not analogous kind of experiences.
So let's talk about, you break it up into liberty, immunity-based licenses, and the least restrictive alternative. Then you go on to immunity-based licenses and ethical values, and we'll walk through those, and then practical challenges. So let's talk about liberty, immunity-based licenses, and the least restrictive alternatives.
Right. So what is an immunity-based license good for? It's good for certifying that you have been infected and would allow you then to do certain things. As you've already mentioned, Howard, travel, maybe work in certain industries, and perform certain functions, or be admitted to a hospital for a loved one because you can't either catch or transmit the infection. And that enhances your liberty if you're a person who has had COVID. And we should remember that at the moment, everyone is barred from, they have to physically distance, they can't do large gatherings, they have to do all sorts of other restrictions, quarantine in certain cases. This actually enhances the liberty of the people who have been infected by COVID. Now, the least restrictive alternative is a principle that has been used in public health and in the law to say, look, when we're trying to affect a public health policy, we have to use the least restrictive method. We have to recognize that the policy might not apply to certain people or might not apply well to certain people, and therefore we shouldn't apply it to them. And so this is a case of, look, the policy of physically distancing, not being able to go into shops, not being able to visit relatives in the hospital, that is not relevant to people who are have experienced COVID and are immune to it. And so it's simply recognizing that principle in the case of COVID-19. And so we think the immunity passport actually enhances the liberty of those people who've been exposed and recovered from COVID-19 and does not further diminish the liberty of those people who are naive to the coronavirus.
Now, Zeke, you've seen the data. We've published quite a bit of it, and we have two more pieces that just went up, which is around healthcare disparities. How do you layer the concern that particularly African-American communities, indigenous populations in the U.S. have had a strikingly higher rate of disease? How do you layer that on top of this notion of liberty and immunity-based licenses?
So we should distinguish the disparities that we're seeing. And here I'm in Washington, D.C. at the moment, and the African-American population is something like 45 to 50% of the city population. But in terms of deaths, it's somewhere around 80% of all deaths are among African-Americans. It's a horrible disparity. But remember, actually, the immunity passport would then, because it's so much more prevalent in the African-American community, would then actually allow these African-Americans who've been exposed to the virus to do the functions and participate in employment activities that I've mentioned. So in some ways, I don't want to say, makes it worthwhile or addresses the disparity, but those are two different issues. The disparity is, relates to probably much more frequent comorbidities in that community, much worse situations, call it housing and other items that might expose them more frequently to the virus, access to healthcare services and institutions lower, and then disinformation that seems to have been targeted to the African-American community about their vulnerability. Those disparities are totally different than the immunity-based passports. And in some sense, I think it's important. There's no discrimination on the immunity-based passport. It's whether you've recovered from COVID or not.
Right. Now, you do talk about this analogy to driver's and pilot licenses. Could you just talk about that similarity?
Yeah. So, why do we have the current situation with COVID-19? Because it's risky and because it poses, potential lethal threat to yourself and others. Why do we have driver's license? Because driving an automobile poses lethal threat to yourself and others. We test people. We make distinctions in gradations. So you can drive a passenger car, but unless you're specially trained, you can't drive a large motorcycle or a truck or a school bus. And similarly with immunity passports, you get certified, but it's time limited because we don't know how long the immunity will last. It may entitle you to do certain things, but not other things. And they're very much the same. And the main reason we're giving you this license is public safety. We're protecting other people and we're allowing you to do something because you're safe, you're not going to infect other people, and you're not going to be infected yourself. And I think the analogy is actually quite good in point of fact.
Now, you then go into some ethical values, and we'll go through them one at a time. There's four that you mentioned.
Yeah.
The first, immunity license could maximize benefits by safely enabling social and economic activities such as patronage of bars and restaurants.
Yeah. If we have an immunity passport, people might be able to then sit inside at bars and restaurants when we reopen. They might be able to go to get their hair cut or dentist's office or other things that require close physical contact. As I've mentioned, it also will permit people to visit relatives in the hospital or a nursing home. And that might also be preference for hiring them because they're not going to transmit the virus from person to person to person if they work in a healthcare facility or in a nursing home or in other places, prisons, where transmission, because of the tight concentration of people, the inability to physically distance appropriately, might make it problematic to have people who could transmit the virus if they were infected.
Immunity license. immunity license.
Sorry, and
Go ahead.
that would be good for everyone, right? It would be good for example, relatives who are patients in the hospital. It'd be good for the residents of nursing homes and hospitalized patients.
Well, when I envision the future, I can see how we can get to some places. Opening restaurants is not one I can really see. That's the hardest one, and you and I both like going out to dinner. Second, immunity licenses can be consistent with priority to the least advantaged. Could you explain what that term least advantage means?
Yeah, well, one of the key ethical principles that has been, I think, risen to prominence, you might say, over the last 50 years is that it's important to recognize who the least advantaged, and most of us have an intuition that they should be given special attention because they have had multiple disadvantages in life. I remember, I think it was Franklin Roosevelt who wrote that, the measure of society is not what we do for the well-off, but what we do for the people with the least well-off, and to make sure that, they have an equal chance in life. This certainly doesn't, immunity-based passports doesn't undermine those people who have been least advantaged in life. And it, in some ways, the people who've been disadvantaged by getting infection have a certain advantage here in having recovered from it. So I think it's important. One of the things we've heard is that this somehow is discriminatory,
right,
that an immunity-based passport is a discrimination. I will say it's got a differential impact on people, right? Some people are going to be allowed to do certain things that other people aren't. So people who are recovered from COVID can engage in certain activities that other people cannot. Now, a differential impact is not necessarily discriminatory if it doesn't rest on some artificial category that isn't relevant. But being infected with COVID is a relevant category to spreading infection. And so we recognize that. And it's important, I think, to distinguish differential impact from discrimination. Not every differential impact is a result of discrimination and ought to be quashed. And I think that's a distinction that is often hard for people to understand and grasp.
Now, you then go into practical challenges. We already talked about one, which is that the science needs to work. So let's do away with the science needs to work.
Yeah.
But some of the others are payment. Like, this is going to be expensive. Right. Nothing in the U.S. healthcare system is inexpensive. You and I have talked about that. If you want to make it expensive, put it in the U.S. healthcare system. So how can you imagine payment would work, or how would you get the license and maintain it?
Well, I think that actually is one of the bad parts of our current system, which is we often charge people, rich or poor, the same amount of money for a license or a procedure or things like that done by the government. And I think that's quite bad. I think that if we're going to have immunity-based passports, they have to be free. And now we have, payment for the test. So we should definitely ensure that if you've got a test, you get a serology test, you should not have to pay for the passport or the license in addition to that. And I think that's just a basic requirement. I think of it kind of like a poll tax. It should not be a poll tax. And I think, making people pay a lot for their driver's license is also a surreptitious tax on the poor that is not really fair.
One of the other challenges, you and I, your dad was a pediatrician, I'm a pediatrician. We talked about the so-called varicella parties of my youth and my children's youth. So you confer an advantage on people, and then they go, right, I'm 25, I'm 30. My two boys, are 27 and 30. Go get infected and you get your serology passport, your immunity passport. How do you prevent that?
I don't think you can fully prevent that.
Okay.
We are a society of individual rights, and we want people to be able to exercise their rights and make choices about their own life and how much risk they're going to take. We allow the, people to do extreme sports. We allow people to go skiing, to bungee jump, and all sorts of other things that have real risks. We allow them to drive cars, and they have real risks of death. So we're not going to get rid of it entirely. On the other hand, you don't want to incentivize behavior that does carry some serious complications. And unfortunately, even though they're low among people who are younger, they're not zero. As the latest round of Kawasaki cases or strokes in young people has alerted us to, this isn't a totally benign disease in young people. It is relatively benign and it's pretty low risk, but it's not zero risk. And so we should think of ways of disincentivizing these kind of parties. Like you, I did have a varicella party for my children. Didn't work, but we did try it. And I do think that one of the ways we can think about it is maybe starting the immunity-based licenses with healthcare workers, nursing home workers who've already been exposed, or people in the food service industry who have already been exposed. So these are people who are not likely to go out and expose themselves, likely to be fully informed about the situation, and their passport in the situation would be beneficial. But we can think of other ways of kind of restricting and disincentivizing the behavior. But as I said at the start, I don't think there's any way we can 100% prevent it, as long as we like people to have liberty and structure their own lives and take some risks in how they pursue their lives. I think it's inevitable that some people are going to, and probably already have gone out and gotten self-infected.
Well, tens of millions went out this weekend as the states opened up. So it's clear that tens of millions of people are willing to take some risk.
Yeah.
Before we turn to other subjects, and there's some questions, some of which we've touched on, I wouldn't say it's been a great 3 or 4 months for the FDA, the CDC. So who becomes the licensing body?
I think that's a really good question. And you also want to create a license that is very hard to fabricate or forge or counterfeit. And so I do think you have to have some non-hackable electronic certification. Probably the states are going to do it. That's the way we do it in the United States. We do it with driver's license that way. The FAA does pilot's license, but I do think the states are probably in the end going to have this responsibility.
Do you think it's...
And by the way, I think this is coming.
Yeah, I was going to say, that was is it inevitable, Zeke? Do you think this is inevitable?
I think it is inevitable, and I'll tell you why. I think what's inevitable about it is countries, Chile, Germany, have already said they're going to probably use this. If New Zealand becomes virus-free, you can imagine that they're going to want people to come in only who can demonstrate it. And one way of demonstrating it is either a 14-day quarantine or an immunity-based license. One way maybe of getting around the UK 14-day quarantine, if you want to get there, is an immunity-based license. So I think it's going to be the travel that originally puts it out there and sort of forces the United States to adopt it. I would also say I haven't heard a knockdown argument against this. So I think there's going to be pressure from people to begin developing it. Just imagine if you were a parent of a child going to school, or you were hiring a nanny or something like that. You would do your own, immunity. You might very well do your own immunity-based passport kind of requirement. And so I think if it starts out haphazard, and we have it, I think you're going to get an organized system for it. So I do think it's almost inevitable.
Can you imagine one of the concerns that I've thought through, you're at Penn and let's say 10% of your workforce has been infected, and, you can test, that they have serology, whatever it lasts, 3 months, 6 months, 9 months, you'd follow them and we'll know that will evolve. As I said, you and I are more convinced that we'll get it right on the science. And we'll begin to know at 3 months, 99% of people are still protected, or whatever the timeline is, and you'll have to be retested. But can you imagine within a healthcare system, you have 20% of your surgeons have been infected, so they draw a different type of responsibility or duty, or ICU docs or ED physicians, and that they begin to object to that you're putting they're always caring for the patients whom it's unknown if they have COVID-19 or they do have COVID-19.
Yeah.
And so you begin to divide your workforce in a way that people may be uncomfortable with. Have you thought through like what it would mean in a healthcare system or at a skilled nursing home?
Yeah, no, I think you're right. If you had healthcare workers who were COVID exposed and immune, you might say it's better for you to work on the COVID floor. And again, we're all doing extraordinary things. This is a crazy time requiring us to work in ways that we hadn't anticipated and haven't done. I think as a doctor, we have to remember our first obligation is to patients. And if we have special talents, and in this case, having been infected with COVID, that allows us to care for patients more safely, I think that's something that's really important for us to do. And I think, as I understand physician duties and healthcare worker duties, this applies just as much to nurses and respiratory therapists, our patient is our highest obligation, and caring for them safely and is really important. And yes, this might put imposition on us and might create some challenges for us, but I don't think we can say, well, it creates challenges for us, but I don't want to do it. We recognize that you have a higher duty as if you're a doctor, and I think that's something. I've been very, very pleased that this generation of doctors seems to have recognized that right from the start of this pandemic. And I think, that just the ethos we have to make sure is prevalent throughout the profession.
Well, I don't think there's been a time in my 40-year career I've been prouder of my profession than in the last 3 or 4 months.
I agree.
I
agree with
you.
You.
Extraordinary commitment to patient care in the face of numerous challenges that we've already gone over. We're going to turn.
And I think the fact that society is recognizing that and using the language of heroes tells you how much the American public agrees with that, and I think how much we really need heroes, average people who are just going to step up, say, "This is my duty. I accept my duty, and I'm going to do it."
So 2 viewpoints. We've been discussing Zeke's with COVID Persad, the ethics of COVID-19 immunity-based licenses, and also there's an accompanying viewpoint by Mark Hall and David Studdard entitled Privileges and Immunity Certification During the COVID-19 Pandemic. But I told Zeke at the beginning I wanted to do 1 or 2 other ethics and policy issues. So human vaccine challenges. I think all the rage 3 or 4 weeks ago, but over the last week or two, some issues have come up. One, isolating the virus, not that easy. Secondly, you truly are putting people at risk, and we have no cure, definitely no cure. Even some of the initial reports, you're seeing a 3 or 4% benefit in terms of fatality, but these are not cures at all. What's your sense of human challenges around vaccines, Zeke?
Well, I think it's an interesting question. First of all, your listeners need to recognize we've done challenge studies in other infectious diseases. It wouldn't be the first. I was a party to talking about challenge studies related to malaria when the military was trying various drugs and going to give them to volunteers and then infect them with malaria. Now, malaria is a little different. We do have treatments for malaria, although can be a fatal illness too. This is different, as you point out. Maybe the mortality rate is 1%, but it isn't 0%. Maybe it's skewed to people over 65, so we don't enroll them, only enroll younger people, but it's not 0. On the other hand, it does seem to me that there's very, very urgent public health, social value to this research and to getting a vaccine out quicker. So I think a lot of the questions are really, you might say, practical. First of all, is this actually going to be faster or not faster?
Right.
It's unclear that this is actually, the main justification for doing this is why wait for people to be exposed to COVID and to see how many people contract COVID? Just get this done faster. It's not clear that this is going to be done faster for a variety of reasons. Second, there's a big question about generalizability.
Right.
One of the big issues here is well, how generalizable will the challenge study on a 30-year-old be to someone who's, say, 65 or 70,
Right.
where most of the mortality is, and where we know the getting immunity from a vaccine is not as common. And so I think, we might end up with a crazy situation of where you do a challenge study on 30-year-olds, and yet the predominant people who you want to get the vaccine are people who are 70. And you don't know anything about it. So it may not have as much social value as a regular study would be, even if you would, sort of dichotomize. We'll try for safety reasons in under 65 first, and then in over 65s. So I think those two challenges, not as fast, and it may not be generalizable. You may not get the kind of information, the valid scientific information to make a judgment, are really, really important to answer before we went ahead with a challenge study. I think in principle, given a 1 or 0.5% mortality rate and a very informed population, it wouldn't be unethical in principle.
Second, Sherry Gleed was on a live stream about 10 days ago, and we talked about two issues: small practices, which are really struggling. My Lord, they are really struggling in hospitals. Yeah. And Sherry mentioned around hospitals, she said, look, I need more data to really understand what this year is going to look like for hospitals. Some may not do as poorly. They have a cash flow problem at the moment, but if elective surgery comes back and they can make it up, billing comes in for the intensive care patients they've taken care of. If they have global payment contracts as an insurer as part of the hospital, they may do okay. She just said, I don't know. She needs more data. She's more concerned about small practices. But this weekend, you wrote a piece that there are some real winners, and it's insurers. Could you elaborate a little bit about what you said in that piece? I did read it, and I know what you said, but I think people would be interested because you think they need to share some of what could be some huge benefits. Like Geico's given, some of the car insurance places are giving money back. Right.
So because of the drop in elective surgery, even the drop in hospital admissions for other things.
Yeah, ED visits are plummeted.
Exactly. Right. ED visits, and, where did all those myocardial infarctions go? Insurers are doing well. Now, we should remember, not all of that money is theirs. If there's a self-insured employer, my employer, the University of Pennsylvania, is self-insured. So it's not actually the insurance company that administers the contract that's actually saving money. It's Penn that is, and we could get to how employers should handle this. But it is the case that insurers are making money. They're making money on Medicare Advantage. They're making money on commercial, the exchange patients, and they're, I think, are doing some things. We've heard of ones that have advanced money to practices and have made various policies that have helped the physicians as well as patients. But we think they should be doing more. Many of them raise two objections to us, to our demand that they do more. One objection is, well, the elective procedures will come roaring back. Hospitals want to make profits. Now, I think that is a worry. It's a legitimate worry. But I think it raises two issues for me. One is, why the hell are we paying so much for elective procedures? Shouldn't we redo our reimbursement system so that hospitals are not making their money on elective procedures like hip replacements and knee replacements and back surgeries? That seems to me, if this is how hospitals are making their money, we ought to rethink what we're paying for those procedures, and maybe lower if all the profit margin is there, and raise payment for more necessary medical care. But the second thing I would say is, I'm not convinced, not at all convinced, that these elective procedures are going to come roaring back. Remember, there is a supply problem, a supply issue, which is, yes, hospitals and surgeons and others may want to do these elective procedures, but you got to have patients who are willing to get the elective procedures. And I'm a little more skeptical that we're going to have a lot of patients lining up to get those elective procedures. For one thing, a lot of people with back pain, the tincture of time may take care of it. And for another thing, a lot of them, I think this residual fear of going into the hospital may last a lot longer than insurers are recognizing. And so there may be, in fact, it might not roar back at all. And we might think of other ways that we sort of put a pause on these elective procedures. I've been a big advocate of what's called shared decision making, that you really have to use a formal informed consent process where patients get the actual data on their procedure in general and the procedure at the particular institution before the institution will be reimbursed for it, because we know if that's done well, a lot of patients don't want those elective procedures. Nonetheless, I do think insurers need to make it easier. And I agree with Sherry Gleed as you portrayed her, which is that it's the independent small practices that need help.
Yeah.
And I think there are a lot of things insurers can do. We're working with a number of them to try to think about switching them to capitation.
Yeah.
That's a good thing for the system. Why just, bail them out? Make sure we have a structural transformative change that everyone's been trying to get. Make sure we institutionalize telemedicine. Make sure we go to capitation so doctors have a different incentive structure when we come out of COVID. I think this would be a huge benefit to everyone, and would use this moment of crisis for longer term, more sustained treatment. But I think insurance companies need to be creative, and they need to get into the dialogue. I also have recommended, there's a patient component here. And one of the things insurers might do is rethink the deductible copayment situation. I think I've long advocated, why are we charging copays and deductibles for primary care visits? We want to encourage them, and we should have no deductibles and no copays for those primary care visits and get patients to orient themselves and their care to primary care doctors. Similarly, I think for generic medications, I think those are relatively cheap to everyone, and we should have no copays for those. So I think there's a variety. Each category here, the independent primary care doctors and other specialists, the hospitals, and especially the patients, insurers could be creative in helping out. And I think we're probably going to see a lot of action on that.
Last question, then I'll let you go. Thanks, Zeke. The presumptive Democratic nominee is Joe Biden. And a few weeks ago, someone said to me, "Oh, did you hear Mr. Biden's recommendation or suggestion or policy initiative of lowering the age of Medicare to 60? I go, "No, I didn't." And then I was reading about it. And, Medicare now is very different than Medicare 10 years ago. 10 years ago, it was all government run. Now it's 35, 40% Medicare Advantage, private insurers who've done quite well in that market. The recommendation of lowering it to age 60, do you think this is feasible, passable, if he were to become president?
So let me say two things. First, I think coming out of COVID, even halfway through COVID, you're going to see a huge push for universal coverage. Not 90% that we have now,
Yeah.
but a huge push. Because I think the uncertainty and insecurity that is being created by COVID, people are going to demand on healthcare, I need security. And I do think there's going to be a big push. How you achieve that, how we get to universal coverage, is the right answer to lower the Medicare age? Is the right answer to create Medicaid for all and say, if you don't have Medicare, you don't have employer-sponsored insurance, you're on Medicaid, and that's that. And everyone's got it, and we're going to federalize it so we don't have the Texas and Alabama and Georgia and Florida saying, no, we're not going to expand the Medicaid coverage. I do think there's going to be huge pressure. And what exactly the resolution is, I don't know, and which approach we take, I don't know. But I would not be surprised if we end up in 2022, 2023 with a much expanded healthcare coverage. I hope as we go there, we make the system simpler, because it's gotten so complex, and figuring out what you're eligible for is a real problem. But I would also mention, Howard, given 33 million Americans have lost their job, a lot of them are going to be losing their employer-sponsored insurance, even with insurance companies maybe stepping up and waiving premiums or giving premium holidays and stuff. There is going to be a lot of people who are caught without insurance. Maybe they're in Texas, they're unemployed, they're not poor enough to get Medicaid, but they're not eligible for the exchanges. It's going to be a lot of people are going to be demanding coverage, and the system, as we've known it, is not going to be able to solve that problem. And I think that creates a political pressure. There's obviously got to be other things. Political pressure is not enough. It's a necessary but not sufficient condition. You're going to need what's the plan, and you're going to need a change in the government so that the Senate would have to flip and the presidency would have to flip. But neither of those are unimaginable going in to 2022. I do have to say I find it a little strange in this moment that President Trump has decided that it's his moment to declare we got to get rid of the ACA. That just seems hard to understand as a response to a healthcare pandemic. So
it's interesting when I spoke to Don Berwick. We did a live stream last week about just how medicine and society will change. No one's a grander, wiser thinker than Don, and he said, the 55 million people who feel most secure with their health insurance at the moment are the people on Medicare, not Medicaid, not private insurance. It was very interesting. Who feels most secure? And it's someone who's 65 or older, whether they're on private insurance or Medicare, because if they lose their job, they can get Medicare. And he thought that would have long-term implications about how people think about this from a personal standpoint.
I think he's right. I think I learned this as an oncologist. The most powerful, extremely powerful sentiment, emotion is uncertainty. People hate it. And I think right now there's a lot of uncertainty around health insurance. And I think people are going to I need security there. I don't want this uncertainty anymore. And if it could happen to me, we've got to solve this problem. I think you're going to see something happen.
This is Howard Bachner, Editor-in-Chief of JAMA. I've been talking to a really remarkable colleague and member of the JAMA editorial board, Zeke Emanuel. Zeke's the Diane Levy and Robert Levy University Professor, University of Pennsylvania, Vice Provost of Global Initiatives, and Chair of the Department of Medical Ethics and Health Policy. Zeke, as always, thanks so much for joining me today. You're just a pleasure to chat with. Thank you, Howard. It's been wonderful. Great questions. Be healthy. Be safe. Thank you. See you, Zeke. Take care. Bye-bye. Great.